Good evening. I am Dr. Anil Parikh, Medical Director, IPCA. It's a great pleasure and privilege for me to welcome the medical fraternity across the country on this hypertension CME with particular focus on current update and reappraisal uh, as well as focus on thiazide diuretics role in hypertension. It's been IPCA's endeavor to continuously take part in CME activities over the years, and hypertension is one of the focus areas for us at IPCA. And we have research work on hypertension as well as extensive participation in the CME activities on hypertension. And IPCA has been at the forefront of low-dose chlorthalidone uh, in hypertension. That's our work. And then we have today for a galaxy of speakers in both international and Indian speakers for today's CME, and we have also galaxy of moderator as well as chairperson. So to chair today's session, we have Dr. Srinivas Kumar, who is known all over the country and one of the most prolific interventional cardiologists, which we can have, I think, one of the foremost prolific interventional cardiologists. He is Director of Cardiology and Clinical Research at Apollo Hospital, Jubilee Hills, Hyderabad. He is Professor of Medicine at Apollo IMSR, and with a distinguished academic background and recognition as a Fellow of the American College of Cardiology. He is a leading expert in coronary intervention, as I said, structural heart interventions and mitral balloon valvotomy. His contribution extends to across leadership roles during his tenure as president of the Andhra Pradesh Cardiovascular Society and also as a program director of the ACS India, and now it is known as TCT Plus India. He is a key visionary in advancing cardiovascular techniques, as I think Professor Venkatram was just mentioning about his tremendous zeal in this regard, and with various initiatives like Finding Foundation and Indian College of Rotablation and Cardiac Imaging. His research and clinical innovations continue to shape the future of the interventional cardiology. Then we have Professor Venkatram, which I think requires no introduction to us, to most of the clinicians in India. And I have been fortunate to associate with him right since my postgraduate days, and he has been a guiding light for us, for all our academic activities on hypertension. Currently, he is Director, Academic and Scientific Affairs of the Indian Society of Hypertension, and he is Professor of Clinical Medicine, University of Texas, Blood Pressure Institute, Dallas, Texas. Dean Maguire University Medical School, Sydney, Australia. And he's one of the founding member of the American Society of Hypertension, has served as both chairman and board of governor of ASH. And he is rated as one of the topmost experts on hypertension in the world and in the WHO list. He has authored more than 410 plus publications and 9 books on hypertension and various chapters, and outstanding clinician, educator, and researcher on hypertension. Recipient of the Lifetime Achievement Award, Moser Award from the American Society of Hypertension, and has received Padma Shri from the Indian government for his work on hypertension and prevention of heart disease. And as per former Health Minister Dr. Harsh Vardhan, described Ram as the global hypertension icon of the century. So we are fortunate to have him moderate the session for today. And then we have a galaxy of speakers, which is led by with Dr. Matthew Wire, who is a distinguished nephrologist and Professor Director, Division of Nephrology, University of Maryland, Texas. And he has written more than 700 manuscripts, book chapters on various topics. He has edited 8 books on topics of nephrology, transplantation, and hypertension. He is present at numerous international scientific association meetings, hospitals, and medical schools. Dr. Wire currently receives manuscripts for more than 30 major medical journals, including the American Society of Nephrology and Archives of Internal Medicine. So, a galaxy of work which he is doing, and he's chairing various on the board of the various 18 journals, section editor of current hypertension reports, current opinion in hypertension and nephrology, associate editor of clinical nephrology in the American Society of Nephrology. He has 5 active NIH sponsored grants from NIDDK as well as NHLBI. In addition, he is a member of numerous associations, including American Society of Nephrology, National Kidney Foundation, the American Heart Association, and the American Society of Hypertension. So we look forward to today's talk by Dr. Matthew. And then we have Dr. Vivian Fonseca, who has been well known to us all because he is very active at ADA sessions, then also in India at various RSSDI. We are fortunate to hear him all along. And today, we are very happy to have him amongst us. He is Professor of Medicine, Assistant Dean for Clinical Research, the Tools Tulane Alumni Chair in Diabetes, and Chief of the Section of Endocrinology at Tulane University Medical Center in New Orleans. He has been past President of the Science and Medicine of the American Diabetes Association and has served on ADA Board of Directors and several committees, served on the Board of Directors of American Association of Clinical Endocrinology and the Board of Trustee of American College of Endocrinology. He has received several awards, including Benting Medal for Leadership and Service from the ADA, the Seal Harris Award from the Southern Medical Association, the Gerald Reven Award from the World Congress on Insulin Resistance, and 2024 Mentor of the Year Award from SSCI, and many more. Dr. Fonseca has lectured in US and abroad, and he has published over 500 papers and review articles. He is the editor of the textbook of clinical diabetes, translating research into practice, and several monographs and book chapters. I think he's also quite well known in India, and we look forward to his take on hypertension and diabetes together. Next, we have Dr. Tukaram as Professor and Head of Nephrology. He will be today's panelist. He is Professor and Head of Nephrology at GS Medical College and KM Hospital, Joint Director, Roto Soto, Mumbai. His career spans over a decade of serving in nephrology, during which he has developed expertise in the management of CKD, acute kidney injury, kidney transplantation, and various renal-related complications. He has contributed significantly to nephrology research and a number of publications in high-impact international and national journals. So he will be today's panelist on the nephrology side. Then we have Professor Anil Bhansali. We have known him for long in India. He is very well known because he has been the professor and HOD of endocrinology at PGI Chandigarh, and more than 500 publications with high index, HI index, which is very high, and more than 50,000 citations. He is a BC Roy awardee, prestigious BC Roy awardee, and former president of the Endocrine Society of India and Punjab RSSDI, and author of clinical rounds in endocrinology, and pioneer in community research, as well as he is the pioneering in research effort in stem cell therapy in India. So we look forward to Professor Bansali's take on today's deliberations. Then we have Dr. Akshay Bafna, a young interventional cardiologist and electrophysiologist, an additional professor and HOD of cardiology, RCSM and GMC, Kolhapur, interventionist cardiologist at Star Super Specialty Center and Clinic at Kolhapur. He holds multiple prestigious qualifications from DM Cardiology from KM Hospital, and additionally, he has completed a diploma in cardiology from Johns Hopkins University. He is a fellow of the prestigious societies like ESC, CSI, as well as FSC. He is also fellow of the American College of Cardiology. He is an expert in adult and pediatric consultant and interventional cardiologist. Through his innovative research and clinical expertise, he is doing a pioneering work. So we look forward to his take on today's deliberation. So I think these are the today's panelists. With that, I invite Dr. Srinivas, who has taken his time and is going to chair today's session. So I request him to start the proceedings.
Thank you, Dr. Anil, for the elaborate introductions and kind words for us and all the speakers today. Indeed, it's a great pleasure and honor to be chairing this session in which stalwarts in hypertension like Dr. Ram and others are speaking. And I must be extremely thankful to IPCA for this possible, and also Dr. Venkatram sir for agreeing for this. And we were very fortunate, and all the Indian doctors who logged in, I was told about 2,000 plus doctors are getting benefited by this program. And we welcome Dr. Matthew Weir, Dr. Viviana, and then our Indian colleagues too, Dr. Tukaram, Anil, and Akshay. It's a great opportunity to interact among the different specialties. Nowadays, we become focused and more tubular vision, but hypertension is one field where all of us together, like cardiologists, nephrologists, endocrinologists, and broad-based, all of us together can contribute a lot. As we understand, the hypertension is increasing leaps and bounds with the changing lifestyles in our country. And in today's, as of now, I think India is suffering with the highest number of hypertensions along with diabetes, and the combination of it is leading to more and more morbidity and mortality. And if you understand that hypertension itself could lead to 50% of the cardiac diseases and significant number of kidney diseases too. So if we can all learn and treat this hypertension properly, we could save so many lives and prevent so much of morbidity. And we have very good drugs now with less of side effects and more optimal control. But the problem is of compliance and the education. So more and more such opportunities and more such programs, interactions with international faculty will help us to increase our knowledge and then probably pass it on to the patient's benefit. And we wish all this will percolate down to the patient care, and our patients become and stay more healthy. With these few words of introduction, I think if our panelists, did they join or they want to say anything, or I'll hand it over to Dr. Venkatram sir. Did they join?
The panelists will, after the talk, they will serve.
Okay, no problem. Dr. Venkatram sir has been pioneering instrumental for this. I request him to say a few words before handing it over to our first speaker, Dr. Matthew Weir sir. Over to you, Dr. Ram.
Okay, thank you, Srinivas. Dr. Matthew Weir has already been introduced. He's going to be the speaker, and he's been introduced, and everybody knows him in the field of nephrology, hypertension, transplantation. And I became aware only not too long ago. He was the chairman of the Data Safety Monitoring Board for the CLIC trial. So, which is very, very interesting thing, because a lot of times we don't know who the chairman of the Safety Monitoring Board is unless something goes wrong. So that was an important study. We are very fortunate that somebody who has been like that is a part of this panel discussion. So I will ask Dr. Matt Weir to give his comments, and maybe he will stay for panel discussion. I'm not sure. He's got something to do. Matt, please take over.
You're on mute, Matt.
Oh, there we go. Good morning. Good evening, everybody. Thank you, Venkata, and thank you for the invitation. It's a great pleasure to visit. The only thing that would be better would be to actually be there with all of you, because I absolutely love Indian food, and it's one of my favorite, foods to eat. So that's my only disappointment, is I can't be there with you today. So what I'll do first is share my slides, and we'll get started. And I just want to make sure everybody can see them. Here we go. Here we are. I take it everything is visible now, so I'll get started.
Go ahead.
Basically, yes, I mean, we can see them all.
Yeah, everything is perfect, sir. Please go ahead.
Great. So I'll be focusing initially on hypertension and chronic kidney disease, and really try to provide some perspective about how things have changed and how we've learned, particularly about how thiazide-like diuretics really are an important aspect of controlling blood pressure, even in people with more advanced forms of kidney disease. These are my disclosures, none of which are specifically targeted towards conflicts with my presentation today. So for an overview, we'll talk a little bit about the pathophysiology of hypertension, just as a as a background. I'll cover some traditional considerations about the use of diuretics for the treatment of hypertension. Then we'll talk briefly about blood pressure targets, which obviously has always been an area of debate and discussion, although it's become, I think, better clarified in the last few years, particularly with the results of the SPRINT and the STEP studies. And then we'll really focus on some of the newer data looking at the use of diuretics in people with more advanced forms of chronic kidney disease and summarize. So let's appreciate in a given patient, it's hard to know which is the most important system that may be at fault for higher levels of blood pressure. We obviously have the sympathetic nervous system, the renin-angiotensin system, and then the final arbiter of handling sodium and water, and that is the kidneys. And as I'll discuss, both germline and then somatic mutations over time can alter how the kidney senses volume, sodium, and regulates the volume status, and is probably one of the most important aspects of regulation of blood pressure. But we have to appreciate the sympathetic nervous system is very much involved. There are both afferent and efferent aspects of it, which comes into play. But remember this, whether we're talking about the sympathetic nervous system, as you see here, or the renin-angiotensin system, if the pipes are full, which is what I like to explain to medical students, then it's very difficult to control blood pressure. So we really need to pay attention to the major hormonal systems, but I think we also need to appreciate that if volume is not adequately controlled, the use of medications to block the sympathetic nervous system and the renin-angiotensin system are often not successful. And that's why I think we need to really pay attention to these. And of course, the renin-angiotensin system is very important, plays a very important role. You'll also see at the lower left, it does impact aldosterone, which is obviously also a very important factor, which influences the handling of sodium, particularly in the distal nephron. But the point I would like to make is, despite all these regulatory systems, the volume status of the patient is very, very important. And one of the things that probably changes with age, which again could be related to a variety of different structural factors, regulatory hormones, the environment, sodium exposure, I can go on, is that our ability to excrete salt and water requires a higher level of blood pressure. And this is probably one of the most important factors, particularly associated with aging and decline in kidney function, which is important, that needs to be targeted as part of our therapeutic considerations. We're all familiar with the blood pressure equation, as you can see here, where the mean arterial pressure is equal to cardiac output times systemic vascular resistance. And you can see how the hormonal systems at the bottom of the graphic feed in. But please note in the very middle, the impact of sodium and water handling by the kidneys and the volume is also critically involved as a central process. Now, many have suggested that RAS blockade should be considered the foundation of antihypertensive patient therapy in people with chronic kidney disease, again, because they lower blood pressure, they reduce proteinuria. But a fact that many of us forget is that dietary sodium offsets both the antihypertensive and antiproteinuric effect of ACE inhibitors and angiotensin receptor blockers. And isn't it interesting that there are also published studies showing that the use of diuretics can actually recover some of the antihypertensive and antiproteinuric effects of dietary sodium under these circumstances. And that is why, obviously, the use of diuretics in conjunction with other major antihypertensive therapies has been really one of the most important aspects of our strategies to better facilitate blood pressure control. I take nothing away from calcium channel blockers or renin-angiotensin system blocking drugs, or even beta blockers for that matter. But if one does not adequately deal with blood volume, it's going to make it very difficult to control blood pressure. And which is why there's been a lot of discussion about, what are your best first, second, or third therapies. But the reality is the vast majority of patients need 2 or even 3 blood pressure medications, preferably in lower doses, in order to avoid individual medication-related side effects. And central to that, obviously, we've learned over the years that diuretics remain an important part of this approach, and has certainly been well recommended by a broad variety of guidelines, as you see here. Now, as far as the kidneys go, we have to appreciate that there is a very tight relationship between blood pressure and kidney damage. And obviously, this has been well described in experimental models of rats who have been studied with a variety of different medications, as you can see here. Lower blood pressure is associated with less glomerulosclerosis. And if you block the renin-angiotensin system as part of that, you further reduce the likelihood of glomerular kidney disease. And the reason for that is that the filters like to operate at about 1/2 to 2/3 of systemic blood pressure. So it's critical to appreciate that the filters become more vulnerable to higher levels of blood pressure, and particularly so with damage to the afferent arteriole, which regulates the inflow of pressure into the filter. And this happens in people with hypertension, diabetes, and aging of the vascular structures. And what it does is it diminishes the ability of the kidney to auto-regulate blood flow into the filter. And this creates greater risk for hydraulic injury and increasing proteinuria, and consequently glomerulosclerosis. Now, there have been lots of studies over the years to specifically address what is the right blood pressure to prevent kidney disease progression. Believe it or not, there have been only 3 published studies looking at 2 different levels of blood pressure in people with non-diabetic chronic kidney disease. And basically, they've been smaller studies, but nonetheless good studies. And it clearly shows the benefits are most evident in people with more protein in the urine. And in diabetic kidney disease, there have never been studies showing with 2 levels of blood pressure reduction what is the ideal level of blood pressure. But loads of secondary analyses are consistently showing that certainly blood pressure levels below 130 are very important to utilize to reduce both kidney and cardiovascular events in people with diabetes and reduce kidney function. It was not really until the SPRINT study, which Dr. Ram mentioned earlier, that really the evidence supporting lower levels of blood pressure was clearly demonstrated. And you will appreciate from this figure that the benefits start to accrue very early on. Again, recommendations driving systolic and diastolic blood pressure down below 130/80, consistently beneficial across the board, even in older patients. And although there was not evidence in this study for chronic kidney disease progression, in large part because we didn't recruit a lot of people with chronic kidney disease, there was unequivocal evidence that even if you do have kidney disease, there are fewer cardiovascular events. People don't die from kidney disease, they die from cardiovascular disease. So obviously then, we need to speak specifically about how to better get the blood pressure down in people with chronic kidney disease. And there are a variety of different types of diuretics that you should be familiar with. Now, when I grew up as a young lad in medical school, I was always taught once the GFR is below 40 or 50, you should be using loop diuretics to facilitate better blood pressure control. And of course, you know, the great debate is, do you use them even in people who are clinically euvolemic? And, you know, the bottom line is, for a large part, diuretics were ignored unless they were loop diuretics in people with more advanced chronic kidney disease. But, you know, it's interesting. With continued efforts to better study how to treat blood pressure, there is now evidence that thiazides, and particularly thiazide-like diuretics, and I'll show you the data, are effective even in people with advanced chronic kidney disease. And we strongly suspect that this is an effect of vasodilation, not necessarily volume reduction. And certainly, if you do have a volume problem, you can use thiazide diuretics as part of your effort to use both thiazides and loop in terms of better facilitating diuresis if necessary. But what's fascinating about the clinical pharmacology is that these types of diuretics facilitate natriuresis and lower blood pressure even in NCC knockout mice, because it's always been thought that the sodium chloride cotransporter may be the major target of these drugs in the distal convoluted tubule. But the fact of the matter is these drugs lower blood pressure well, even in knockout models, and even in people with Gittleman syndrome who lack a functional sodium chloride cotransporter get blood pressure reduction with thiazides. Now, there are some differences between the available thiazide and thiazide-like diuretics, such as chlorothalidone, but again, the differences probably explain some of the potency differences between these drugs. I'll spend more time on that in a minute. But I think we can appreciate that inhibition of NCC does lead to natriuresis and an acute reduction in plasma volume. But the reduction in venous return results in decreased cardiac output, and then obviously the blood pressure goes down. But what's fascinating is that even with chronic use, cardiac output returns to pre-treatment baseline, and yet the blood pressure remains down. So we suspect that the major benefit of these drugs is vasodilation, and as you can see, decreasing responses to angiotensin II and norepinephrine, perhaps through K-channel effects and or calcium desensitization of vascular smooth muscle. There have been a number of good studies that have been done to study the potency of thiazide diuretics, and you can see here comparing hydrochlorothiazide, chlorothalidone, and bendroflumethiazide that there are huge differences. And these are therapeutic equivalents to reduce systolic by 10 millimeters of mercury. So you don't need much chlorothalidone to go a long way. But isn't it interesting how the guidelines have evolved? This was what was written 12 years ago. And you can see loop diuretics are recommended for those with estimated GFR less than 30. Wow, okay, so it used to be 50, now it's 30. And, you know, obviously we know about the use of combination of thiazides and loops. But what about just lowering blood pressure? So some historical data to start with. You know, if you go back and look at the older Mr. Fit data, what's fascinating is that there is actually a better blood pressure reduction and more reduction in cardiovascular events in people treated with chlorothalidone. And if you look specifically at cardiovascular events measured yearly and time to event, you will see quite consistently that there is lower cardiovascular events in people on chlorothalidone compared to patients on hydrochlorothiazide or placebo. and fewer cardiovascular events was consistently observed, with huge p-value in the middle bullet point there. And of course, quite likely the real benefit is better blood pressure reduction. And there's even been lower LDL cholesterol with it. So, I mean, fascinating observation. And there have been other studies that have been done to clearly show that there are less heart failure, less cardiovascular events, even with the systolic blood pressure adjusted analysis, so that the benefits of the therapy are above and beyond what you would see simply by reducing blood pressure. So a lot of these older studies are quite fascinating in this regard, and you can see that here favoring chlorothalidone, and with sizable reductions in the relative risk for cardiovascular events. So I think the bottom line is we don't know fully what are the relative benefits, but it's clearly there. And again, more of these types of mediation analyses need to be done to further understand more about the potential benefits in this regard. So let me go back now to chronic kidney disease. This was a beautiful study that Rajiv Agarwal did. It was actually an NIH grant. I was one of the original reviewers. And the whole idea was to assess blood pressure reduction with titrated doses of chlorothalidone, as you can see, starting with 12.5 and titrated, if need be, up to 50 in 160 people with a GFR of 23. And the bottom line you can see there, with 24-hour ambulatory blood pressure monitoring at 3 months, the mean reduction in chlorothalidone was 10.5 greater than placebo. And you can see that shown here. Very consistent benefits. So the old story that you can't use a thiazide-like diuretic to lower blood pressure in CKD really should be put at rest with the results of this study. And also importantly, reductions in urinary albumin excretion. And I think, again, the combination of lowering blood pressure and reducing urinary albumin excretion are critical factors to better facilitate kidney protection over time. So to summarize, basically the antihypertensive potency of hydrochlorothiazide and chlorothalidone are clearly different. It's really 3x with chlorothalidone. Comparative effects on reducing cardiovascular events are hard to distinguish given the lack of head-to-head clinical trials, but definitely appears better with chlorothalidone, and it may not be simply better blood pressure reduction. We just don't know. And there are also side effects which are dose dependent. So again, in some patients, using lower doses coupled with your renin-angiotensin system inhibitors does make sense. But to put it all into perspective, you can use thiazide-like diuretics in people with lower GFR. They do help, they do make a difference, and it's probably through vasodilatory mechanisms. Though, again, individualization rather than generalization is needed. Higher doses may be required in some people to lower blood pressure, but, I think the bottom line is individual choices are important, but in many patients, with chronic kidney disease, chlorothalidone can certainly be a very useful adjunct to better facilitate blood pressure control. So thank you very much for your attention. I'll look forward to the Q&A later.
Thank you, Dr. Matthew, sir, for excellent coverage and highlighting the aspects of how volume status is important in controlling blood pressure, also highlighting the role of diuretics in appropriate control and taking us through some of the newer data of click trial. We request you to stay till the discussion, no? So otherwise we can have some question. You'll be available. Thanks for that. And then in that case, then we'll probably go for the next lecture, which will be dealing with, again, a lot of questions are already coming on diabetes and hypertension together, how they are more worrisome and more problematic, what is the appropriate treatment. We have Dr. Vivian Fonseca talking to us on this important aspect. And I think after all the three talks, then we will have quick discussions and Q&A sessions. Over to you, Dr. Vivian.
Thank you very much. I first of all like to thank Dr. Venkatram for inviting me here today and for IPCA to support this program. It's always a pleasure for me to interact with people from India. I wish I was there in person. Maybe we can do that in the not too distant future. So let me put this into full screen. Okay. So I've been asked to talk to you today about management of hypertension and diabetes, an important duo. Just talk about some basic principles. Much of what I'm going to talk to you about is not new. There's a lot of old data, but we seem to be lacking the ability to implement this in practice. It's not just, it's all over the world. However, there's some new studies, and I'm going to show you one at least that I've been closely involved with very important new data. So hopefully we might rethink this whole problem. And it's very important because we have known for a long time, this is the Mr. Fit study that Dr. Bear talked about, that if you have hypertension and diabetes, your risk of cardiovascular events is so much more. And this is what we are seeing in our clinical practice day to day all the time. Somebody pointed out, I think Dr. Venkat shared with me this slide about calling them the vicious twins, diabetes and hypertension. We have for many years used the term ABCs of diabetes, which was A1C, blood pressure, and cholesterol, trying to emphasize that diabetes is not just about controlling glucose. You have to have a global perspective, reducing all complications. So for cardiovascular, you certainly need good blood pressure and lipid control. For kidney disease, you certainly need good blood pressure control, as Matt has just pointed out, as well as glycemic control. And there are other things like retinopathy, where blood pressure also interacts with diabetes, with glucose, and makes retinopathy worse. So there's good data on that. And if you take this problem of the two diseases together globally, there are millions of people all over the world who have the problems, and many of them are actually not well controlled today. So we have an opportunity to do something about it. Now, I mentioned that the ABCs of diabetes, and I wish we had more studies like this, which is the STENO-2 trial, which showed treating all is in a combination. They attempted, they didn't achieve it. This is many years ago. They didn't quite have all the tools we have today, particularly for treating glucose and lipids, but just attempting to get to goal led to a 53% reduction in endpoints, which is a remarkable result. And we should be striving to achieve this in our clinical practice today. So let's see how we can do this. Let's start with simple things. Lifestyle change, which has to be in the background. Somebody put in the chat box a question about the salt intake in the Indian population. It certainly is a problem. Salty snacks are everywhere, and people are taking that. It's really nothing but fried sugar and salt together, and it really drives both the glycemia and the blood pressure. Blood pressure is lowered by weight loss and salt restriction. We've known that for a long, long time. Today, we are very focused on weight loss for improving glucose control. But if you look at all the studies with SGLT2 inhibitors and GLP-1 receptor agonists, even if they are focused on glucose or weight loss, the blood pressure comes down. We can get into nuances in discussion about the role of potassium and magnesium. We know about the DASH diet. Actually, the DASH diet studies initially excluded people with diabetes because of the carbohydrate issue, but the DASH group have just finished a study on the DASH diet in people with diabetes and hypertension, and I'm looking forward. I was on the DSMB, and the results will be presented at the ADA in June. And of course, exercise in the background, just simple exercise like walking every day would make a difference. So here's the DASH study. This is just in people with hypertension, showing that moderate changes of low sodium intake lead to quite substantial changes in blood pressure. And this is something we should remind our patients about regularly. Here's a summary of many of the trials that have been done in the past. SHEP, Sisture, all of them showing tremendous reductions in stroke, CBD, mortality, cardiovascular disease. One thing I want to point out to you is the difference in groups. I mean, these people started off in SHEP with blood pressures above 160. The control group had systolic of 155, and even the treated group was 156. Of course, these were older people, but we can do much better than the levels that were seen in these trials. Yet you got very substantial reduction in risk, and I think that reflects the high baseline. But there are still people out there who have blood pressures in the 150s and 160s that we could improve. And there are many diabetes trials that have attempted to do this. They start with the UK PDS, compared to less tight blood pressure control, good blood pressure control led to a reduction in diabetes endpoints, diabetes death, stroke, and microvascular complications. And to emphasize the point that treating hypertension actually improves retinopathy progression. Now, when ACE inhibitors came out, we were all very excited. This is a class of drug that's going to change everything. ARBs were a little refinement on that, maybe a little less side effects. We said, forget about diuretics. We have to treat everybody with ACE inhibitors. And then came the ALL-HAD study. And the ALL-HAD showed basically not much difference between, in general, for the primary endpoint between ACE inhibitors and the diuretic group. In fact, all the treatments except for alpha blockers were equal on the primary endpoint. But when you get into subgroup analysis, particularly with comparison with amlodipine and maybe to some extent with lisinopril, the diuretic group actually did better. I want to point out that chlorthalidone was the drug used, the diuretic used in ALL-HAD, as well as in many of the other diuretic-related trials, such as SHEP, etc. And the reasons for that was the better blood pressure control over 24 hours that Matt pointed out to you. I think 24-hour blood pressure control is very, very important because in people with diabetes, you lack the nighttime drop in blood pressure, the so-called dipping due to autonomic neuropathy is lost, so you don't drop your blood pressure at night, and that's not good for the heart. And with a long-acting diuretic like chlorthalidone, that is somewhat attenuated, and you get better blood pressure lowering. But we'll come back to that later on. I just wanted to point out here that chlorthalidone was the drug used and chosen by NIH for many of the studies they funded. And here is the further reduction in coronary artery disease and CVD, etc. Now, then we had the ACCORD study, where we did not have a good outcome with very tight blood pressure control. ACCORD was a bit unfortunate in the study design. It had a 2x2 factorial design, and there was an interaction there between tight glucose lowering and tight blood pressure lowering. I think we overdid the tight glucose lowering a bit too much and gave people hypoglycemia, and there were problems there. So in the end, it turned out that in ACCORD, there was not a good outcome with good blood pressure control, nor with good glucose control. But all that has since changed with further trials that have just come out, and we'll talk about that. Around the same time, the ADVANCE study showed that tight glucose control and tight blood pressure control led to a reduction. And if you had intensive glucose control and an ACE inhibitor or diuretic, you had much better outcomes compared to the standard glucose control group. So here's the ACCORD study. We achieved a blood pressure of 120. We maintained it and yet did not see the benefit because of this interaction with the group that also had tight glucose control that led to more complications and problems. So there was no conclusive evidence that intensive blood pressure control reduced cardiovascular disease. And so targeting a blood pressure less than 120 was thought to be not beneficial in people with diabetes. But around the same time, maybe a little later, the SPRINT trial came up, and that showed a good benefit for reducing blood pressure less than 120, but people with diabetes were excluded from SPRINT. So that raised a very important question. What's the difference between diabetes and no diabetes when you're choosing a target? And I think that has now been addressed with BP roads, which I'll show you in a moment. But I think the problem of ACCORD was the study design. So here's the BP road study just published in the New England Journal of Medicine, and I think it was in November. I was on the data safety monitoring board for this study. It was done in China with a group from Shanghai leading it, but done quite remarkably during the pandemic. They carried on, maintained good blood pressure control, close to 120 in the treatment group, and saw a significant reduction in cardiovascular benefits. And the study was over 5 to 6 years. There's a lot of other sub-studies within BP roads that is being analyzed right now. Improvement not just on cardiovascular events. I think we were very interested in improvement in cognitive decline, which has become, I think, a major issue in our populations as the populations age. And good blood pressure control and maybe good glucose control is also important in those groups. So we do need a blood pressure down to 120. I wonder whether the ADA will rethink its guidelines now after seeing this result. And maybe we should do it a bit slower than we did it in the ACCORD trial. So here's where the recommendations are from the ADA and the guidelines. Patients with a blood pressure more than 120 should be advised to lifestyle change, right? Don't let it go further. But once it's gone above 140 or 140 over 90, you should promptly initiate pharmacological therapy, not wait till 160. And of course, lifestyle modification, as I mentioned. And then we have to do test for microalbuminuria, which is very important in stratifying patients for treatment because of the good evidence that albuminuria, even microalbuminuria, is a problem, and using RAS blockade as a treatment of choice in that particular group has advantage. For those without microalbuminuria, you can do anything. You choose any of the drugs you want, and the goal of therapy till today in the guidelines is less than 130 over 80, but I think that should really change. So this is a little bit more detail on the ADA's recommendation. This is from last year. Just repeating what I said, but if you don't have albuminuria, you can use a RAS blockade, you can use a calcium channel blocker, and you can use a diuretic as well. So you can choose any of those. For those with albuminuria, you start with an ACE inhibitor or ARB, but if you don't get good blood pressure control, you don't get to target, you then should add in a second drug, either calcium channel blocker or a diuretic. And if your initial blood pressure is more than 160, start with 2 agents. I think that too is an important consideration. And you have fixed dose combinations of diuretics with the RAS blockers. So we should continue therapy, keep adding therapy as needed. Many people need 3 drugs. Some need more than that. And this is the concept of resistant hypertension and the role of the aldosterone in that. It keeps coming up in discussions, but I don't have time for that today. There's another group called the Diabetes Cardiorenal Metabolic Group. Dr. Ware and myself are both on it. There too, we decided on 130 over 80, but again, I think we will revisit this with new data that has come in. They emphasized a few other things, and I want to recognize that many of you know Dr. Bakris, who used to really push for these things about taking the blood pressure properly in your clinic. Have the person sit for a few minutes, not just rush in and out. And check also for orthostatic blood pressure, especially in elderly people and with diabetes, because you may have autonomic dysfunction. And I won't repeat the drug choice of drugs. You've already heard what I said there. I want to emphasize that, Dr. Ware talked about the advanced CKD group, but even earlier, you can risk stratify your patients based on microalbuminuria and then choose your therapies accordingly. So let's go into specific drugs. Diuretics have low cost, but they're the disadvantages people have talked about, hypoglycemia and dyslipidemia. The changes are actually very, very small. And these were seen in all hat. They were extensively discussed, and it was felt that it was not worth worrying about it for most people. Occasional people might get a big jump in blood glucose, but that can be taken care of by appropriate therapy. Sexual dysfunction is commonly listed there for diuretics and beta blockers. I think much of this comes from the fact that early trials started off with a blood pressure that was very high, over 160, and reduced it substantially by 20 millimeters of mercury. We don't need to do that anymore. We should start therapy earlier, and you get less of this problem. ACE inhibitors and ARBs have specific effects on nephropathy. As we have heard before, this is not true. You have generic now to take care of the cough, and you get some edema with calcium channel blockers, which remain very effective in clinical practice, although in clinical trials, they didn't show major advantages. There have been other studies like the HOPE study, where small reductions in blood pressure led to great benefits, indicating that maybe RAS blockade has other benefits. I've been very interested in beta blockers. We did studies in diabetes and found that some of them, like carvedilol, did not impact insulin resistance and A1C as much as others. But this is relatively old data. But also using microalbuminuria monitoring over time to see whether patients are progressing, where you may need to be more aggressive, compared to people whose microalbuminuria goes down or almost to normal, and they have a better prognosis. So this is important for risk stratification, not just at diagnosis, but also as you go along. So to emphasize again, multiple studies show RAS blockade even early in the course of the disease. I think Matt showed you some people even later stages of the disease. You should carry on, not stop it as the renal function is worsening. Here's the renal study showing a benefit. Now, the relative risk reduction is small, but the absolute risk reduction is not huge. So the disease still keeps progressing, and we need to be aware of that. And this issue came up when newer drugs became available. You had a benefit, but there's still residual risk. It varies depending on the population you study. So reducing the slope of this line is still very important, particularly when you're treating people early in the natural progression of disease. So we were very excited when SGLT2 inhibitors came out. They showed a reduction in heart failure that was quite dramatic, but also in progression of chronic kidney disease, and a wide range of people whose GFR was greater than 90, people whose GFR was less than 60 to 90. In the early studies, they hadn't looked at people with more advanced chronic kidney disease, but they subsequently have, and there too you see a benefit. So we are now not recommending that you reduce or stop it if the GFR is low, because there's a renal benefit. You might not get the benefit on the glucose lowering to the same extent, but you still get the renal benefit. And here's the Credence study, which is done specifically for chronic kidney disease. You also have DAPA-CKD. They all show a very significant reduction in progression. Here's DAPA-CKD showing the same thing with dapagliflozin. Also importantly, in DAPA-CKD, they had people without diabetes, and they too also got a benefit. So here is a glucose-lowering drug that's helping people without diabetes because of a number of mechanisms in the kidney as well as elsewhere that might help. And another approach that has recently gained attention is the use of mineralocorticoid receptor antagonists, particularly finerenone, because it has some anti-inflammatory effects in the kidney. So let me, I think I had a slide, maybe it's coming on, what happens with diuretics in the SGLT2 inhibitor trials. There's a subgroup analysis showing very clearly that people in the Credence trial who were on diuretics did better than just with canagliflozin alone. So there may be some beneficial interaction. Part of it may be related to better blood pressure control. So don't exclude diuretics just because your patient is on an SGLT2 inhibitor. They might have additive benefits. So which diuretic? And first of all, comparison with other classes. You see diuretics having a benefit, particularly for CHF and mortality compared to placebo, compared to beta blockers, compared to calcium channel blockers, and low-dose diuretics compared to ACE inhibitors in some situations is beneficial. In others, it is not. So if you do subgroup analysis of thiazides versus placebo in various trials, you see, and with long follow-up, some of the SHEP has a long-term follow-up of 14 years. Cardiovascular mortality is reduced. All-cause mortality is reduced. So thiazide diuretics have been shown to be very beneficial. Here's some more studies I showed you all had earlier. So here's the study I wanted to show you. Here's people in the canagliflozin trial, the Credence trial, people who were not on diuretics as well. Here is their risk of the outcomes, whereas with those with diuretics had a reduction. So good, favorable interaction between the two. So which diuretic, which thiazide? And there are very limited data on head-to-head comparisons. At least there are on outcomes. There certainly is on blood pressure. Here is the HCT effect on systolic blood pressure of hydrochlorothiazide. Yes, it has a good effect, but with chlorthalidone, it is faster and a greater, significantly greater reduction in blood pressure. And now if your goal is going to try to get to 120, any bit of additional reduction certainly makes a bit of a difference. And then what about blood sugar level? This is the same study looking at hydrochlorothiazide's effect on blood glucose. Both of them, chlorthalidone also over time, but there's no placebo group, so we don't know how much of this is natural progression of blood glucose in a pre-diabetes group, but it is greater with hydrochlorothiazide compared to chlorthalidone. So I was pleased to see that the RSSDI came out with some guidance and guidelines for management of hypertension in patients with diabetes. Many of my colleagues and friends are authors on this paper. They have emphasized that low-dose thiazides have demonstrated their success in mild to moderate hypertension, and particularly emphasized chlorthalidone having superior blood pressure reduction in patients with resistant hypertension. And they have made the statement that diuretics such as hydrochlorothiazide are not recommended in diabetic hypertension because of the elevation in fasting glucose and A1C. But despite that, hydrochlorothiazide continues to be used globally. I think we should bear that in mind when we have people whose diabetes is not well controlled, whether you might make a little bit of a difference. So we are winning. I think we are winning the battle, or at least making some. We haven't completely eliminated CKD and CVD, but just think about how bad things were many years ago when we had no specific therapy. GFR in people with diabetes was falling by 10 mils per minute per year. So even if you were at 90, you couldn't be complacent. You could drop. Some of them could drop quite substantially. We made a major advance with the arrival of RAS blockade in the 90s, and then little advance on that was the ARBs. And then with the development of SGLT2 inhibitors and specific non-steroidal mineralocorticoid antagonists, we have made a lot of progress. So now people with diabetes can hold their GFR loss to just 2 to 3 mils per year. And that's a big change from where we were 20 years ago. So I think we should look for better prognosis with our patients if we do this right. Thank you.
Thank you, Dr. Vivian, sir, for highlighting the importance of the various drugs and highlighting the roles. And you touched upon the which diuretics. I think we have Dr. Ram, sir, clarifying more on it. A lot of questions have come already on that, and we'll hear more about it. And Dr. Venkatram, sir, is known to clarify things more clearly. And we are all waiting to hear his thoughts on which diuretics to prefer. Is there still controversy or is it is done? With this, I request Dr. Ram sir to take over and deliver his lecture. Over to you, sir.
Can you all see the slides?
Yes, sir. Yes.
Okay. Thank you, Matt, and thank you, Vivian, for discussing the cardio-metabolic renal connection to blood pressure and the ultimate survival or lack thereof in patients with hypertension. What I would like to do is, based upon a number of guidelines, various choices we have, and reconsideration of the role of diuretics in the treatment of hypertension over the years. As all of you know, that ever since the guidelines have been started for hypertension, starting with JNC1, and then European guidelines, then World Health Organization guidelines, and various regional guidelines, they have always included diuretics in the treatment of hypertension. I know that sometimes beta blockers were in, sometimes beta blockers were out, but one class of drugs that has been maintained among the choices has always been diuretics for the treatment of hypertension. I mentioned to you about JNC1, which started the concept of guidelines for hypertension, of course, a long time back in 70s. Since our audience are from India, I would like to mention that the first chairman of JNC1 was a person of Indian origin, Ike Kishan, who was at Mayo Clinic. And he was the chairperson of first JNC, the fact that all of you should know. In terms of South Asians or Indians having high risk, European Society of Cardiology, European Society of Hypertension is the first large society to come out openly and to declare that people of South Asian origin, namely Indians, have a 40% increased risk of all complications at the same level of blood pressure as their Caucasian counterparts. A first time, a guideline document has identified Indians as a high-risk category at the same level of blood pressure. The exact reasons are not known, metabolic syndrome, CKD, whatever it is very, very high. Subsequent to European Society guidelines, American College of Cardiology, American Heart Association have made an appendix to their previous guidelines, and they also have characterized Indians as a high-risk category. And World Health Organization did not want to be left out, and they also jumped onto the train and described Asians as a high risk for cardiovascular disease. So, ladies and gentlemen, one thing we have to accept is that we, people of Indian origin, are at high risk from hypertension, at a higher risk than their counterparts wherever you are. So your genetic basis itself has conferred you a 40% increased risk, which suggests that blood pressure and other factors should be controlled very, very aggressively. Vivian has shown some blood pressure guidelines in diabetes. Basically, they're very similar to general guidelines in the treatment of hypertension. It doesn't matter which guidelines you follow. All of them are now converging towards 130 or 80, few millimeters here, few millimeters there. Don't worry about that. But I think now the current standard is 130 by 80 is the goal for the treatment, irrespective of the level of blood pressure, irrespective of gender or comorbidities, unless somebody is very, very fragile and unable to take cardiovascular drugs. So, ladies and gentlemen, we have to get away from 140, we have to get away from 90, and then we have to accept 130 or 80 as the goal, which will remain at least for next 10 to 15 years as far as I can tell. Now, this is a very interesting analysis done as an editorial in a journal that majority of cardiovascular complications occur in people with blood pressure less than 140 over 90. I did not say above 140 over 90. I said less than 140 over 90. So these are the people who have a blood pressure 130 to 140, 80 to 90. So ladies and gentlemen, the highest mortality in patients with measured blood pressure is between 130 to 140, 80 to 90. So what does it mean? That is a segment where you have to pay a lot of attention and don't ignore 135, 136, don't ignore 85, 86, because these are the most vulnerable group of patients who have measured blood pressure. Very, very important to know how this window, 130 to 140, 80 to 90, is the highest risk for cardiovascular disease. Now, we have, it's interesting, what goes round comes back. It is applicable to hypertension. 90 years, let us call it 100 years, just for discussion's sake. Ladies and gentlemen, in 100 years, we have come one full circle. Full circle. This is a study, 1935, which showed that ideal blood pressure should be 120 by 80. But if you increase the blood pressure by few millimeters of mercury, you reduce the survival by 4 years. If you increase the blood pressure a little bit more, you decrease the survival by 8 years. If you increase the blood pressure a little bit more, you decrease the survival for 16 years. Ladies and gentlemen, 1935, 90 years ago, or let us call it 100 years ago, they suggested that blood pressure at 120 or 80 provides longevity. Any incremental blood pressure decreases the life expectancy. So we are now talking about 2025, and the ideal blood pressure should be less than 130 by 80. If it is 120 by 80, if the patient can tolerate, that should be the best blood pressure. Now, I think some of you will be interested to know what I'm going to tell. The reason why we are treating hypertension is because of this trial called Veterans Administration Cooperative Trial, done in late 60s and early 70s. What the Veterans Administration Cooperative Trial has shown that when you treat hypertension, you lower the cardiovascular events. That's all. So untreated hypertension versus treated hypertension, this is the most monumental study which suggested that if you treat hypertension, you decrease cardiovascular events. And since then, we started treatment of hypertension. Now, what is astonishing, Vivian and Matt and others probably know it, this study had only 360 patients, 360. 180 patients in placebo group, 180 patients in the treatment group. In the treatment group, they had 30 deaths. In the placebo group, they had 50 deaths. So 50 deaths, 30 deaths, that was statistically significant. And the total number of patients in this trial were 360. This kind of a trial will never be accepted for publication anymore. So on the basis of a relatively small study showing significant differences between treatment and non-treatment, we are now treating hypertension, hopefully a little bit more aggressively than before. Now, we have diuretics, beta blockers, ACE inhibitors, ARBs, calcium channel blocking drugs, direct vasodilators, centrally acting drugs, And now in US, endothelin antagonists, you have a wide variety of antihypertensive drugs, which can be used either monotherapy or as a part of combination therapy. Now, the debate for many years has been which diuretic to treat hypertension with. Is it hydrochlorothiazide or is it chlorthalidone? That has been a debate that has been raging for 40 to 50 years. Now, finally, after the 60 years advent of diuretics, now in 2024 and 2025, ladies and gentlemen, this debate is over, the controversy is over, and the consensus has been reached as a result of two major trials that were published last year, one in New England Journal of Medicine and other in JAMA Cardiology, and I'll show you shortly. The differences between hydrochlorothiazide and chlorthalidone, Dr. Matt Ware discussed very briefly. The absence of the second benzyl ring bestows upon chlorthalidone a longer duration of action. So compared to hydrochlorothiazide, chlorthalidone has a longer duration of action. As you can see here, pharmacologically, when you look at the doses, the duration of action of chlorthalidone is much longer than that of hydrochlorothiazide, as it was already shown by Dr. Matt Ware. The one study that was mentioned, actually Vivian also mentioned, a systolic hypertension in the elderly program, first study to look properly at what happens to elderly when you treat hypertension with diuretic, namely chlorthalidone. When they use chlorthalidone-based therapy, there was a 60% reduction in risk of stroke in SHEP. Other complications were also reduced, but a significant reduction of stroke. And since then, ladies and gentlemen, we have been treating hypertension in the elderly a little more aggressively because you reduce the risk of stroke. CKD, coronary artery disease, heart failure are important complications, but there's no complication more embarrassing to the patient and the family as stroke. Stroke is a devastating complication of hypertension, and with chlorthalidone therapy in SHEP trial, it was significantly reduced. And hypertension detection follow-up program, which was an earlier study, again looked at chlorthalidone-based therapy, that the mortality was significantly reduced in patients who received chlorthalidone-based therapy. Mr. Fit trial is a longer trial comparing hydrochlorothiazide to chlorthalidone. You will notice both the drugs reduce the blood pressure, but the magnitude of fall in blood pressure was greater with chlorthalidone compared to hydrochlorothiazide. Consequently, regression of left ventricular hypertrophy was more in chlorthalidone group compared to hydrochlorothiazide. This is not a condemnation of hydrochlorothiazide or interrogation of hydrochlorothiazide, but when you compare chlorthalidone to hydrochlorothiazide, there is a greater fall in blood pressure with chlorthalidone and a greater reduction of left ventricular hypertrophy. ALLHAT trial, the largest hypertension trial ever done. Such a trial will never be done again, at least during my lifetime, showed that in patients who received chlorthalidone, there was a remarkable reduction in the development of heart failure. All complications was reduced, but chlorthalidone-based therapy reduced new onset heart failure by a significant percentage, even compared to an ACE inhibitor. This is a study that I did along with Dr. Norman Kaplan. He asked me to do a study between two diuretics and measure the ambulatory blood pressure. At that time, the IBPMs were not automatic. They were actually manual, where people used to pump every hour, and we used to look at the blood pressure. When we did a 24-hour blood pressure in late 70s, early 80s, we noted that chlorthalidone reduced the 24-hour BP much more than hydrochlorothiazide. So this is a first trial, I think, that showed a comparison in terms of blood pressure, including 24-hour blood pressure. This is a trial that Dr. Matt Ware has already shown. And one of the differences between hydrochlorothiazide and chlorthalidone is the nocturnal blood pressure is reduced much more with chlorthalidone compared to hydrochlorothiazide because it's a long-acting drug. It's a long-acting drug, therefore it reduces the nocturnal blood pressure. In other words, it converts a non-dipping patient to a dipping patient. Hydrochlorothiazide also reduced nighttime BP, but the fall in nighttime BP is more with chlorthalidone because it is a long-acting drug, that's all. Then in one study by Dr. Khosla and co-workers about 20 years ago, when they switched from hydrochlorothiazide to chlorthalidone, just a switching study, there was 8 millimeter further drop in BP. So in terms of efficacy, it is a little bit more. In terms of the duration of action, it's a little bit more because of its mechanism of action. Now, this is the segment, most important segment of my talk, where I am going to discuss two major papers that have put the controversy to rest. And this is called Diuretic Comparison Project. First time head-to-head comparison between hydrochlorothiazide and chlorthalidone in patients with hypertension. The first and only study, the major study was published in New England Journal of Medicine, and then JAMA Cardiology published a sub-analysis. Let me show you these studies. Chlorthalidone hydrochlorothiazide comparison study was a study comparing chlorthalidone 12.5 milligram with hydrochlorothiazide 25 milligram, and the patients were followed for 2.5 years for primary outcomes: coronary artery disease, heart failure, new onset renal failure, stroke, etc. And the conclusion was there was no difference between hydrochlorothiazide and chlorthalidone at those doses when they were compared head-to-head in the first clinical trial. When they looked at the primary outcomes, which I mentioned, the event rate was also very, very similar, no difference at all. And when they looked at patients who had previous vascular disease, coronary artery disease, peripheral vascular disease, who had previous vascular disease, chlorthalidone had a greater benefit compared to hydrochlorothiazide. So they mentioned in a subgroup, chlorthalidone was better than hydrochlorothiazide. In the main group, the effects were very similar. But one point that they missed, I don't think it's deliberately missed, but it was missed, is exposure to hydrochlorothiazide was for a longer duration of time compared to chlorthalidone. So in the diuretic comparison project, patients were taking hydrochlorothiazide for a longer time, whereas patients were taking chlorthalidone for a shorter time. And I spoke to the investigators when the study was published. I said, one important point that clinicians needed to know, you missed in your paper, that you should have mentioned patients had longer exposure to hydrochlorothiazide compared to chlorthalidone. And I told them, if I wrote the paper, I would have added a sentence that short-term exposure to chlorthalidone was equivalent to long-term exposure to hydrochlorothiazide, which is what the results have shown. Very important point that was somehow missed in the conclusion. So the findings of the major paper were that both the drugs at the doses were equally effective, and in patients with pre-existing disease, pre-existing cardiovascular disease, chlorthalidone was quietly superior, and that is it. Now, the subgroup had a detailed analysis in JAMA Cardiology, which is a very important journal. So this one, they just analyzed patients with pre-existing cardiovascular disease. Let us look at different complications between the two groups. So if you look at the blood pressure and the potassium during the study, there was no difference in the subgroup. Blood pressure was similar and potassium was similar. When they looked at outcomes, the outcomes were fewer patients in chlorthalidone had heart failure, and fewer patients in chlorthalidone had mortality. So when they compared heart failure, two drugs in heart failure and the total reduction, it was a little bit more beneficial with chlorthalidone compared to hydrochlorothiazide in the subgroup. When they looked at hypokalemia, it was very similar. There was no significant difference between the two groups. By the way, very important to study this. When they looked at acute myocardial infarction, acute coronary syndrome, there were fewer patients in chlorthalidone group who had acute MI compared to hydrochlorothiazide, and non-cancer deaths, coincidental. You should not make any broad conclusions. Non-cancer deaths were fewer in chlorthalidone because they looked at non-cancer deaths. Now, the adverse events were very similar. Hyponatremia was very similar. Hypokalemia was very similar. So the conclusion of this subgroup, this is a conclusion I have taken verbatim from the paper. Chlorthalidone may be associated with reduced adverse cardiovascular events and non-cancer deaths compared to hydrochlorothiazide. So, Mr. Chairman, panelists, ladies and gentlemen, these two studies, one study, but the second was a subgroup, has put to the rest the debate, because this is the only study that compared head-to-head chlorthalidone and hydrochlorothiazide. So in patients with no pre-existing disease, they were very similar in terms of efficacy. In patients who had pre-existing cardiovascular disease, chlorthalidone was paramountly superior to hydrochlorothiazide, mainly driven by reduced incidence of congestive heart failure. Another conclusion that I have drawn is that short-term exposure to chlorthalidone was as good as a long-term exposure to hydrochlorothiazide, because that's what the paper has shown. So these are the conclusions which I have verbally mentioned. It's the first and only randomized clinical trial to demonstrate the advantages of chlorthalidone over hydrochlorothiazide, and especially in patients with pre-existing cardiovascular disease. Now, one thing important for discussion, chlorthalidone low doses like 12.5 milligram, 6.25 milligram are more easily available in India because of IPCA. They make low dose chlorthalidone, which is not available abroad. And this is a study published by Dr. Parikh and co-workers in Journal of American College of Cardiology, showing, using 24-hour blood pressure, that low-dose chlorthalidone 6.25 was as good as hydrochlorothiazide, standard dose 25 milligram and higher. So a very beautiful study using ambulatory blood pressure monitoring and published in Journal of American College of Cardiology. Now I can tell, it doesn't matter, paper was published. My friend and Dr. Fonseca's friend, Dr. late Tom Giles, is the one who reviewed this paper. And now I can tell it is published, and Tom Giles has passed away. He did speak to me at that time about this study, although you're not supposed to. One point of interest for cardiologists is hemodynamic variability, hemodynamic changes. Pulse wave velocity has been shown to be an important marker of excessive morbidity and mortality, because higher the pulse wave, that means loss of elasticity, and the blood vessels become rigid and they're not elastic and they're not vasodilating. Higher the pulse wave velocity, greater is mortality. Lower the pulse wave velocity, reduced mortality. This is a study showing that if you have a high pulse wave velocity, your survival decreases because your arterioles have lost their elasticity, and it is increased cardiovascular burden. So increased pulse wave velocity, higher cardiovascular burden. There is one trial, not an outcome trial, but observation trial that compared pulse wave velocity between chlorothalidone and hydrochlorothiazide, and they showed the pulse wave velocity reduction was much more with chlorothalidone compared to hydrochlorothiazide, at least in terms of hemodynamics, and not an outcome study because it was only for 8 weeks. One thing that has appeared in the literature for quite some time is that patients on hydrochlorothiazide had a higher risk of skin cancer in the long run because of photosensitivity by thiazide. And this is a study that was actually done in Europe, which does not have that much of exposure to the sun. And in fact, the European Drug Council has cautioned about the use of hydrochlorothiazide because of this analysis that is performed in Netherlands looking at this. And there was another paper, again from the same group in Denmark, that hydrochlorothiazide use is strongly associated with risk of lip cancer. And apparently many of the dermatologists there are familiar with this possible association between hydrochlorothiazide and chlorothalidone because of photosensitivity. Whether it could be higher in places like South Asia where there is a more sun exposure, we do not know. But these are papers that were published and I wanted to share. Now, Mr. Chairman, ladies and gentlemen, and panelists, I'd like to conclude with 3 important quotations relevant to our discussion. One quotation is from my former colleague, late Dr. Norman Kaplan, who wrote an editorial in the Hypertension, American Heart Association Journal. He said, chlorothalidone versus hydrochlorothiazide, a tale of tortoise and hare. And a beautiful analysis between tortoise, chlorothalidone, and rabbit hydrochlorothiazide. And he showed that ultimately it's the tortoise that won. Then Dr. Dominic Sika, known to some of us, the former president of the American Society of Hypertension, has written another editorial subsequently based upon the analysis, typical language that is used by Dom Sika. Chlorothalidone has it always been the best thiazide type diuretic. One more conclusion from our own countryman, Dr. Rajiv Agarwal, who was mentioned for the CLIC trial by Dr. Matt Ware. I spoke to him on December 27 about some clinical trials. And then he texted me a message that day, December 27. He sent me a message, which is still with me. And he said, I can quote him. He said, chlorothalidone lowers the blood pressure more than renal denervation, according to him, because he has done a lot of work. So very important quotations from people who have contributed to our current knowledge of hypertension, cardiovascular disease. So Dr. Srinivas Kumar, the previous faculty speakers, Dr. Anil Parikh, and the panelists. In conclusion then, with the analysis that I was able to provide based upon evidence and publications, I think the debate over the choice of a diuretic for hypertension is over. It's an eventual consensus has been reached. I think now, 50 to 60 years, we had a debate. Actually, the debate should not have taken place, in my opinion, but that's okay. Drug development happens, but we are now able to put together. With those remarks, Dr. Srinivas Kumar, I will conclude, and thank you for everybody for your kind attention.
Thank you, Dr. Ramsar, for covering everything in so detail and highlighting the aspect that lower blood pressure, probably 130/80, and maybe still lower in Indians who have a higher risk initially, and also highlighting the aspects of which diuretic. I think that you have put to rest. And the recent trial which got published in NEJM, that's a great thing, which has 13,000 plus patients, and having probably the patients who had a cerebrovascular disease or cardiovascular disease benefited more. That is again highlighting the aspect of chlorothalidone, which has a long duration of action. Probably early morning surge, early morning risk hours are better covered, or whatever reasons we need to see further. but I think without any increase in side effects, but better control of events is a welcome thing by chlorthalidone. I think that's how our sponsor today, IPCA, stresses a lot on CTD, that education needs to be passed more on to the doctors. I think we can have all the panelists and speakers together on the screen, and then we can have some discussion. A lot of chat questions have come already, and then you would like to read them, sir? Can you do that, or shall you want me to do it?
Srinivas Kumar, with your permission, or you can kindly ask our panelists
Yeah.
in no particular order
Yeah.
to make brief comments. You can start with anybody. We have a nephrology, we have a endocrinology, we have cardiology. Please permit us to listen to their brief comments.
Dr. Tukaram?
Yes, thank you, Dr. Matthew and all other speakers for excellently elaborating on the contemporary management of blood pressure, especially the role of thiazides. So my question is to Dr. Matthew Weir. I'm a nephrologist. This is about the mechanism of action of this class of drugs that initially we believed that they are natriuretic drugs and it's the sodium and volume depletion, but now we are realizing that it's more than just a volume and they have some other mechanisms of action as well. Now my question is about their excellent blood pressure control. And now if you get a patient in whom we get to see the asymptomatic hyponatremia, so often we do that, we get to see that. So how you best deal with this complication when patient is not symptomatic, he has responded excellently with regards to the blood pressure. So here probably similar to the blood pressure reduction, mechanism of hyponatremia in this class of drug also is probably multifactorial and not just the solute depletion. So your thoughts on this, sir?
Yeah, it's an excellent question. The real issue is just how hyponatremic are they? Is it stable? Is it getting worse? Quite honestly, most of the hyponatremia I see with diuretics is in older patients who may not have a good diet and are very thin. But it can happen, almost in anybody. But, if they're dropping below 130 and it's a consistent observation and it's getting worse, you're probably going to have to opt to go on to other therapies, quite honestly. But it's very rare, but it does happen. But there's no obvious solution. You just don't tell them eat more salt. I mean, you could, but that doesn't help their blood pressure either. But it does happen. And it's, there's no easy treatment for it. Maybe use a lower dose and just monitor them.
Can I give you an endocrine perspective on this? I think
Sure.
hyponatremia is less a disorder of water excess than sodium depletion. So there are people who drink a lot of water and they get out of balance. And if they can't excrete it for a number of reasons, either their ADH is slightly excessive or the receptors affected in the kidney, that could cause the problem a lot of the time.
Yeah, at least in some of the patients we can get away by restricting the water intake. It
Yes.
has been compulsive. Yeah. Thank you, sir. Thank you so much.
Dr. Anil, sir?
Srinivas Kumar, can I make one comment? I was going to wait,
Yeah.
but interest of the audience. What Vivian said is probably the most precipitating reason for hyponatremia is this tremendous water drinking, because their urologist has told them that it dissolves the stones. Their gastroenterologist has told them that you will not have constipation. And all these people, they keep on drinking water, especially water bottles. Everybody now, the size of the water bottles keeps on increasing. They have one water bottle here, they have one here. In the backpack, they have two of them. And many of them walk into the plane. I don't want to be in the aisle seat because I'm hit by these water bottles in backpack. So I think if somebody sees hyponatremia, the first thing one should do is probably take water as needed, because there is one mechanism that tells you need water, that is called thirst.
Great,
Okay.
sir. I think a lot of health advisors also now tell take plenty of water, plenty of water. People are taking liters and liters of water for that reason.
And Vivian can comment very briefly. That is, we are endowed with mechanisms
Yeah,
without having excessive water.
yeah. Sir, already
At
mentioned.
least,
Dr. Anil, sir,
excuse
you were
I
telling
will
something.
just add one thing here.
Yeah.
Because as you
Yeah.
talked about the hyponatremia associated with thiazide-like drugs, then water excess may be the one of the reason, fine. But if it is not, and person is having a hyponatremia with chlorthalidone or hydrochlorothiazide, then you should always look for a fractional excretion of potassium and uric acid. The uric acid will be higher, and a fractional excretion of potassium will be lower. So that will be a clue for hyponatremia associated with the use of diuretics.
Okay.
Dr. Akshay, you want your comments? Is he there? I think I see him.
One thing is very, yeah. One thing is very important is the add-off on diuretics, other from metalazone, which is again added to increase the efficacy of probably the diuretics, which is
Good
usually done
diuretic.
in heart failure patients.
Yeah, heart
So
failure
these are
plus
the drugs
CKD.
which are going to, yeah. So these are the drugs where you will have an more hyponatremia associated. In our clinical life, I think probably the hydrochlorothiazide are more commonly associated with hypokalemia, and chlorthalidone is associated more with hyponatremias. But again, the doses in the Asians
Hello?
We lost Srinivas Kumar.
I think.
cause hyponatremia very rarely, unless you have been, as we have advised, one of taking excess drinking water, and another thing add on diuretics into is there for heart failure probably, or for some other indication. So all these things will bind up to cause more hyponatremia only otherwise.
Okay. I think one more, thank you for those comments, panelists. One more thing which I was very impressed was the graph which is shown how to prevent the progression or worsening of GFR. When nothing was there, actually progression was happening about 10 ml per minute, that was shown. And then with the advent of ACE inhibitors, receptor blockers, it is slowly decreased. But with SGLT2 inhibitors, actually the prevention of worsening of CKD was actually further more. So there's no direct comparison between these two, but I always felt that SGLT2 inhibitors are another great drugs to prevent the progression or worsening of CKD and fall in GFR. And that was shown very well by the speaker in that graph. And then a lot of questions came regarding the salt restriction and usage of diuretics. I think that aspect is covered, but any further things, some chat questions came, sir. Are you too particular that salt should be avoided in patients of hypertension taking these diuretics? Your comments, Dr. Ramsaran?
Yeah, I will comment also. I'll comment very quickly. Very brief comment from our panelists, very brief, and then Dr. Bansali and Dr. Bafna, if you have any comments, if you can do it. Somehow my screen, I can't see everybody. I hope you are able to hear me.
Yeah.
If you can just comment, and then we'll go to the full.
Okay. So my comment on a salt intake along with the thiazides is that the optimal amount of a salt intake should be there, because the thiazides are more effective in presence of the optimal salt intake rather than a salt deficient state.
Okay.
Yeah,
I
I
think
do agree to sir. Usually we say that salt restrictions to be considered, but when you use chlorthalidone, I ask my patients to please do continue with the normal diet intake. Do not exceed it. Do not take any extra salt from top. Yes, but whatever is there, you accept it, because thiazide is there to take excess salt. If it is there, it will take and excrete it accordingly.
any other comments regarding the salt? People were very much interested because what is also important to highlight to the large population at large is any of these effects, any of these measures which can control at the population level can produce a lot of benefits than individual patient treatment with each particular drug. That is a point which is to be highlighted, like supplementation of potassium with fruits and then restriction of salt. And by and large, at a population level, that awareness can be created. Actually, it goes a long way in preventing the prehypertensives or the early elevated blood pressure patients, what we call now, to developing into overt hypertension. This is one of the important factors of lifestyle modification, I would say, apart from the exercise and weight reduction, things like that. It's also becomes less important maybe when the patient is already started on diuretic. But to prevent early onset of hypertension, I think these latest the stuff like cheese, burgers, pizzas, which have a lot of stored food with again salt, again go a long way in increasing the incidence
I
of
think
hypertension in society.
I
That
think
aspect
it's
has to
not
be
the
highlighted.
overuse, but it's I think an optimal use is still recommended when someone is on thiazides.
Yes, yes.
Because
After once,
efficacy is better.
yeah,
And
yeah.
second, I think a use which we are finding more useful even in people with diabetes, with hypertension, if someone is having an evidence of hyporeninemic hypoaldosteronism, in that scenario, the chlorthalidone or thiazides are very effective, at least to reduce the incidence of hyperkalemia. So what we have found it's a very useful in that scenario if someone is having evidences of hyporeninemic hypoaldosteronism. And there is one more study to substantiate that is called CLIP study, where they have used even at an eGFR of 30 ml per minute and have shown the hyperkalemia was reduced and there was a further reduction in blood pressure even at a low eGFR with the use of thiazides.
There's a question by Dr. B.B. Kukreja to Dr. Venkatram sir. What is your say on indapamide SR 1.25 as a diuretic versus CTD?
Okay, you can hear me?
Yes, yes. Please go ahead.
Some on screen, I can't see many of you. Okay, it's a question that always comes up. Indapamide has always been available at a lower dosage, but indapamide was first discovered as a calcium channel blocking drug. It blocks the actions of calcium on sarcoplasmic reticulum, and therefore it was calcium channel blocking is a main mechanism. It does have some diuretic action. Pharmacopoeia describes it as a diuretic, but it has got an action on calcium channel blocking drugs also. So now let us accept it as a diuretic. There are fewer trials which have used indapamide for the treatment of hypertension or coronary artery disease in patients. One is Europa in patients with coronary artery disease. One is Progress in patients with hypertension, and HIVET, hypertension in very elderly, which have used indapamide as a component of combination therapy. In all these trials, indapamide-based therapy has been shown to be beneficial. Only thing is, it does not have a larger number of trials where it could be fair comparison, like hydrochlorothiazide, chlorthalidone. Whatever trials it has got, 3 I have mentioned, I don't think there are more than 3, have shown that it is beneficial. Whether this is because of the diuretic action or because of CCB, it won't be known.
Would you consider that it might be having literally benign and lesser side effects in elderly patients compared to other diuretics?
I can't say comparison because there's no comparison as such, but because it's strictly available in low dosage, it probably is like any other low dosages. It is likely to have less electrolyte disturbances with the low dose chlorthalidone, low dose hydrochlorothiazide, etc.
Okay. The another question to Dr. Matthew. Dr. Kirti is asking role and status of ARNI in hypertension, particularly in refractory hypertension. Now that we said that ARNI is coming up faster in Japan, I was told that it is accepted as antihypertensive therapy too. What are your thoughts on that, sir?
I'm sorry, I missed which medication?
The role and status of ARNI, sacubitril valsartan,
Oh, well,
in
I mean,
hypertension.
in the US, it is pretty much restricted and it's very costly, in large part, primarily for heart failure. I would submit to you it is not a necessary therapy if one blocks aldosterone. And I think that's really, with spironolactone or eplerenone. I can tell you I have been treating refractory hypertension for many, many years. And I've never had to require, Entresto, valsartan, sacubitril for treating my patients. Never have had to do that. So I would say, quite honestly, what I tend to use is spironolactone or eplerenone as the choice.
Okay, so it is too costly to be used only for hypertension. That's what you intend to mean.
Yeah, but I mean, I think targeting aldosterone specifically is a much better approach, to be honest with you.
Okay. But once hypertension goes into heart failure, I think they are wonderful drugs. But before that, isolated hypertension without complication, you need not go to such costly drug. That's what I think is the inference. I think one more question is Dr. Badresh Javer is asking, what is the role of renal denervation in India and how many cases done and which centers in India? I think I can answer this. I was involved with the Medtronic renal denervation program. And basically, previously it used to be recommended as an alternative to drug therapy. That can never happen. The previously now how lifestyle modification and drug therapy, how they are, the third pillar of hypertension therapy you could consider as renal denervation. It is not going to replace pharmacological therapy, but it could decrease the dosage, or in some patients, young patients, where with mildly elevated pressures, it could be controlling itself. And the overall dosage of tablets requirement is supposed to be less in patients. And about 72 patients are done in our country as of now, the latest Medtronic data shows. And the response of this therapy in our country is supposed to be slightly better than the data from Europe. But we need to have more patients. And the only thing which is troubling now is the cost. One more ultrasound based, this is a RF energy based renal denervation is available. The ultrasound based renal denervation is also about to be launched in our country. Once the competition comes, then cost also would come down, and probably that we can use it in many more number of patients. I think that I have answered the question. Dr. S.S. Nair, does diuretics potentiate the antiproteinuric benefits of ARBs? I think you can take that question, sir. Dr. Matthew, does diuretics potentiate the antiproteinuric effects of ARBs?
Yes, they do, actually, and it's been well demonstrated that adding thiazide or thiazide-like diuretics to either ACE or ARB does facilitate an antiproteinuric effect, and it's substantial. I would also say, too, that modifying dietary sodium intake, in addition to using an ACE or an ARB, also facilitates an antiproteinuric effect. So it's really the combination of RAS blocker, thiazide diuretic, and dietary sodium modification, which helps, reduce proteinuria. So it should be something that should be considered in all patients.
Is that effect independent of blood pressure lowering, or is it dependent on that to some degree?
Well, to be honest with you, it's hard to say that it's independent of blood pressure, because
the blood pressure is going to go down.
It always does go down, but I've never seen what I would describe as a blood pressure mediation analysis to see how much is blood pressure versus another effect. Because the studies have not been large, but they've been very well done. And they're crossover studies with the same patients. So it is meaningful data.
I think another one interesting question to endocrinology based, Dr. Vivian can take this. As now that you know the chlorthalidone is working well and AGLT2 inhibitors are also better, do you foresee a combination of these two?
That is a commercial decision.
Yeah,
that is a commercial decision. Somebody has to decide. There are two, in my opinion, two very good drugs. So combining the two makes a lot of sense to me. For reasons I don't understand, 95% of the diuretics used are hydrochlorothiazide, despite all the good data with chlorthalidone. And there are not many combinations with chlorthalidone, at least in the United States. So maybe we do need to see more.
Well, there is one with an angiotensin receptor blocker in the US, but that's it. None with an ACE that I've seen.
Angiotensin receptor blocker with SGLT2 inhibitor?
Yes, it's not a well-known angiotensin receptor blocker. Venkata, you probably know which. What is it?
There is a combination with RAS blocker used to be marketed under trade name ZAC. Chlorthalidone dosage.
Azilsartan, sir. It's azilsartan with chlorthalidone.
Yeah, that's the only combination.
Yeah, it was
No,
azilsartan and hydrochlorothiazide.
Yes.
That's
Azilsartan.
No, what they're asking is the SGLT2 inhibitors, not diuretics and receptor blocker. Anyway, that is a commercial decision, as said. I think CTD, the makers, IPCA makers of CTD are actively listening. And if they're pharmacologically compatible, then probably it could be done because both are very useful
I
drugs.
think Dr.
And
Fonseca
especially-
already showed the study with SGLT2 inhibitor with thiazide diuretics. The effect was better. I think he already showed it.
Yes, that is a subgroup analysis
Yeah,
of
subgroup
cretins.
analysis.
It
Yes.
is not a combination pill. That is what
Yeah,
he's
yeah.
asking.
Yeah, yeah.
I think it makes sense based on that data because they are often used together. Maybe, there's one concern, and that is particularly in older people. When you start an SGLT2 inhibitor and they're already on a diuretic, you can get hypotension, and
Yeah.
sometimes the GFR falls to a great degree.
Yeah,
So
yeah.
I would not
Select your patient.
start somebody on the combination. But if you're getting somebody on two separate pills, one is a diuretic and one is an SGLT2 inhibitor, it would make sense to me to combine the two and have it as
Yeah, and
use chlorthalidone.
in all the SGLT2 outcome trials, almost 40 to 50% patients were already taking thiazides.
Exactly. We have the same argument in glycemia, saying, should we not stop using metformin and use these new drugs? But when you look at the trial data, everybody's on metformin and as background therapy.
Correct.
I think we are short of time now. We're running late. And one comment from each of the speakers and Dr. Ramsar especially is in the question from Dr. Adarsh. Nowadays, we see a lot of hypertensive adolescents, especially software professionals and things like that, with and without family history. Then initially they are started on drug therapy and their blood pressures come down. So can we take a chance by modifying their lifestyle and avoiding the tablet intake? What are your thoughts on this? I think India subcontinent purview, then probably Dr. Ram can comment, and in US perspectives, then others can tell.
Dr. Srinivas, if you have a secret to how to change lifestyle of young people, please let us know. It's not very easy.
I think, Srinivas, it's a question comes always because patients like to argue against drug treatment. Very strange. Well, if somebody wants to switch to lifestyle changes, if the blood pressure is under control, that's not a problem at all. Because ultimately it's the blood pressure control, however you do it, with machines, with drugs, with intervention, doesn't matter. With yoga, with anything, copper bracelet, it doesn't matter. As long as the blood pressure goes down, that is the key. You can always change, substitute, but the idea is to make sure that the blood pressure is under good control, and that is what has to be done in practice. People ask this all the time, but there are no data. So I really can't say, okay, go ahead and do it. But if you want to do it on an individual basis,
if the compliant patient and patient are willing to come to us closely when the drugs are stopped, then probably you can try, but we should be very careful in stopping beta blockade. I think that can lead to rebound hypertension rises and complications. And what was the limit of the blood pressure where the drug therapy was started also becomes important, I think. If it was only started just for 150, 100 140/90, then probably still you can take chance and see. But if already somebody had a 200/100, 110, then there is less chance that he would be off drugs. I think those are some of the parameters by which we can decide. And but patient compliance and coming to us for close checkup is very important. Many of the times they think if they're asymptomatic, nothing is happening to them, but they will finally end up with complications and then come to us. Even it happened to one of the mothers of the physician friend. So initially they stopped and they thought everything is under control. Once stroke came, they thought, "Arey, we shouldn't have come for regular follow-up." That's what. Another question is isolated diastolic hypertension, and that what to be done. I think now we are wiser that both diastolic and systolic hypertension are important. Equally, they should be treated. And as we are nearing the time, panelists, Indian colleagues who are three of them who want to any final words before we close, and we hand over to international speaker, and finally Ram sir will close. Any of you want to say any comments or before
Just
we?
I think one comment. The diabetes itself is a state of resistant hypertension, and these patients, they do require usually two or more than two drugs, and particularly diuretics are very useful in these patients.
Dr. Tukaram? Dr. Anil? Sir, you spoke already. Sorry. Dr. Akshay? Are they there? I think if there are no further comments from them, what I would like to highlight is again, though a lot of things are spoken about various types of diuretics and probably chlorothalidone is better, but still I think latest class 1 recommendation is start any drug. Actually, 2/3 of benefit happens with absolute blood pressure control. That becomes very important. So just because you started chlorothalidone, if you use very homeopathic doses, very small doses, blood pressure values are not controlled, then that's how I think Anil sir mentioned that combination therapy becomes effective. The absolute value control blood pressure is very important apart from the type of drug. That drug class effect also contributes to 1/3 of benefits, but we should not ignore absolute control of blood pressure with whatever drug you are using. That becomes more important. With add-on class benefit, with about 1/3 of benefit happens with the type of drugs. So ideally, you should give the combination of both benefits to the patients, but not to ignore just because you started a newer, costlier ARB or things like that. You shouldn't be happy leaving the blood pressures uncontrolled. I think that is very important. And especially in some of the patients who have used some imported drugs, they come with 40 mg, 80 mg of valsartan blood pressures. If you see they're still 180, 100, that is no good. I think that aspect also needs to be highlighted. And that's how the combinations have become very popular. Triple drug therapy, that's what Anil sir also mentioned. And then these are my comments. And final words of conclusion with Dr. Matthew, sir.
Yeah, I just want to thank everybody very much. And obviously Venkataram for inviting me. It's a great pleasure. And I would just comment, remember that low-dose thiazide-like diuretics can be very effective in facilitating better blood pressure control in almost every type of patient, and even in those patients with advanced chronic kidney disease.
Dr. Vivian, sir?
You know, it's very sad that blood pressure control is often neglected, you know, even in diabetes clinics. And we need to emphasize that we need multiple risk factor intervention, as seen in the Steno trial.
Dr. Ram, sir?
Okay, I also want to conclude with few remarks. One comment that I want to make is that medical community may also have contributed to poor blood pressure control. A lot of times when we tell the patients that they have mild hypertension, once we use the word mild, they feel that it is not there. They don't think mild hypertension is hypertension. They think doctor साहब ने बोल दिया mild कुछ नहीं है. Once you use the word mild, you lost the patient because they feel it is there is no reason to treat. So I would encourage all the 2,000 plus people who are in this to refrain as much as possible from using the word mild. You don't use the word mild fracture of the hip. You don't use the word mild cancer. But once you say mild hypertension, the patient shows doctor को भी उतना ठीक है, doctor ने बोल दिया, nothing to be done, बोल के they will never have their blood pressure measured again. So I would encourage our own people to, nothing is mild. In fact, hypertension is always malignant at any stage, because once you multiply 1 to 2 millimeters of mercury, 60 seconds, 60 minutes, 24 hours, and 365 days, it almost comes to 2 crores millimeters of mercury. That's a lot of increase in blood pressure. So I would encourage our colleagues to pay attention to, I don't think they do it deliberately, but when patients are there, attendants are there, somehow we try to give in on the side of the patient, but behave like oncologists. Be very, very strict and read all. And I see in doctors' lounges also, Srinivas Kumar, nothing wrong with the doctors. They can go to the lounge. I go to the lounge. Today I saw that some doctors were talking, Srinivas Kumar, in our lounge, about the romance between Priya Saroj and Rinku Singh for half an hour. What do we have to do with that? These people have nothing to do with hypertension and blood pressure. So what I'm trying to say is, let us focus our own house in order to implement better adherence to the treatment. One comment I want to make is there are 2 trials with ARNI in hypertension. One multi-center trial from Europe, and one like any Chinese trial, a large number of patients, 14,000 patients. It appears to lower the blood pressure as good as any other drugs, but until there is some little bit of outcome, we cannot apply that. So let me make few remarks, and then I'll ask our team from IPCA to also give vote of thanks and way forward. I want to thank Chairman Dr. Srinivas Kumar, the faculty, and the panelists for their participation and for working towards this program since the last 3 months. And I hope that whatever was presented is based on the evidence. And like any other program, I hope that the ultimate beneficiary of this program will be the patients and their families. And thank you very much. Then if I don't know who is going to speak from the IPCA team, I would invite them. Please announce yourself. I can't see all of you on the screen. Johnny, Om, or Sachin.
Sir, Avinash.
Oh,
Yeah.
Avinash, I forgot you. I'm sorry. Avinash, any of you, please.
Respected doctors, very good evening to you all. My heartfelt thanks to our wonderful speakers of today's CME, Professor Dr. Vivian sir, Professor Dr. Matthew sir, and Professor Padmasri Dr. Venkatram sir for a wonderful presentation and giving new insights on diuretic. Thank you so much, sir. I am also thankful to Chairperson of today's scientific treat, Dr. A. Srinivas Kumar sir, for chairing this session and sharing his expertise. Thank you so much, Srinivas. I am also thankful to our respected panelists, Professor Dr. Anil Bansali sir, Professor Dr. Tukaram Jamale sir, and Professor Dr. Akshay Bapna sir for sparing their time and sharing their experience and expertise with all of us today. I also thank the chairperson, moderators, and panelists at 30 different cities and towns across the country, that is from Agartala to Ambikapur and from Jammu to Tanjavur, for attending this program and giving their expertise to the doctors. Thank you so much. Finally, I thank close to 3,000 plus doctors who physically as well as digitally attended this scientific treat today. At IPCA, we are grateful to all of you, sir, because you are controlling blood pressure effectively with chlorthalidone, which is available in a lower dose of 6.25 in India and with all possible combinations. So thank you so much for seeing the difference. Thank you so much. Good night. Thank you.
Thank you.
I think we
Thank
can.
Thank you.